Hello, everybody. Welcome to our webinar. Thank you so much for joining us today for our Share and Learn webinar on reporting to results, the KOHA data story after submission. My name is Janelle Urata, and I'm with the California Oral Health Technical Assistance Center, or COHTAC, and we're really glad to have you here this morning. Next slide, please. COHTAC is funded by the California Department of Public Health's Office of Oral Health, and we're grateful for their continued support. You'll see our acknowledgements and disclaimers on the screen. And next page, please. We also want to thank our planning team and partners who helped make this webinar possible. It was truly a collaborative effort. It included the School Dental Programs Work Group Data Subcommittee, the Office of Oral Health, and our local oral health program partners who are presenting today. So thank you, everybody.
Sorry, Janelle, one second. I
Okay.
wanted to see if I can get rid of that little CDPH, but it's gone now. Okay.
All right, next page, please. Just a few quick housekeeping notes. The session is going to be recorded. We'll share the recording and materials in a follow-up email. We welcome questions and discussions in the chat. Please keep your microphones muted during the presentations. We'll save most questions for the end, but feel free to drop them in the chat as we go. If possible, please include who your question is directed to. We may be able to respond in the chat, or we'll address them later on. We'll also be sharing a short evaluation survey at the end of today's session. Your feedback is super important to us. It really helps us understand what's working, and we can ensure that we can continue offering these share and learn opportunities. We read every response, and we really appreciate you taking a few minutes to complete it for us. So let's take a quick look at today's agendas and objectives. We'll start with some background information from Vaishali at the Office of Oral Health, Dr. Kristen Hoff from COHTAC, and Cherie Sprouse from Stanislaus County. Then we'll move into KOHA at the state level with Shamila and Dr. Victoria from the Office of Oral Health. And after that, we'll hear local examples from Cherie and Christy from the counties. And then we'll shift into communicating KOHA data with Kristen, Marina from San Francisco, and Jodeci from Fresno, followed by Q&A. Xenia will drop a link in the chat where you can learn more about today's speakers. All right, next slide, please. To get us started, I'd like to hand it over to our colleagues who will provide some background on KOHA and the broader context. So we'll send it over to Vaishali.
Thank you so much, Janelle. Good morning, everyone. Thank you so much for being here. I am Vaishali Sundarajan from Office of Oral Health, and I am going to give a quick overview to KOHA. And I know many of you have been working on this program for a very long time, and we also have some new LOHP members. So this overview will make sure we are all on the same page. Next slide. KOHA program has strong legislative foundation. It is part of state law and it lives in the education code. KOHA became state law in 2006 and has been constantly updated through legislative amendments. Basically, KOHA is a one-time oral health assessment between transitional kindergarten and kindergarten or first grade if that is the child's first year in public school. This data gets reported into SCORE. SCORE is the system for California oral health reporting, and this will help the state track participation, identify where extra support might be needed. Next slide. Here is the program history. So KOHA has been evolving for past 2 decades. California established KOHA law and statewide database in 2006, and this was followed by updates like allowing passive consent in 2017. SCORE became statewide in 2019. TK added to the requirement in 2024. And alternate reporting for families experiencing homelessness was introduced in 2025. And overall, these updates make the access easier and reporting stronger. Next slide. So this slide shows the exact language from EdCode. In simple terms, child entering public school must present proof of oral health assessment by May 31st of that school year. This assessment must have been performed within 12 months prior to the student's initial enrollment date. And the law defines kindergarten to include both transitional kindergarten and kindergarten. This proof, as already mentioned, is required only once during the 2-year TK or K program. If a child is screened in TK, they do not need to repeat the screening in kindergarten. Now that we've looked at what EdCode looks like, let's shift to see what KOHA actually tries to accomplish. Next slide. The goal of KOHA is to reduce absences from dental pain, improve school readiness, detect untreated dental diseases early, help families establish a dental home, and provide statewide data to identify gaps. So what is the process to achieve these goals? Next slide. As you can see, there are 8 steps in the process. Number 1, KOHA process starts with a form, either sent home to the parent or completed during the school screening program. Second step, a licensed dental provider or professional fills out the form. Step 3, the dental provider gives the completed form back to the parent so the parent can return it back to the school. After that, schools collect all the forms. Then step 5, schools enter the data in SCORE. So SCORE is state's reporting system. Finally, step 6, 7, 8 is analysis of the data, interpretation, and communicating the collected data. Slide 7, next slide. So this diagram shows how our KOHA partners work together. Each group involved, which is schools, dental providers, parents, school districts, are all mentioned in green color in the slide. Starting from the lower left, dental professionals, they complete the KOHA assessment. Moving to the right, parents provide consent, return the completed forms by May 31st. At the top, schools distribute the form, collect the form, enter the data. Following the purple arrow to the upper right, districts compile all the collected data, submit it into SCORE by July 1st. Everyone has a role to make this process smooth and effective. Next slide. So here are some resources you can access to know more about this program. Most updated KOHA forms are always available on the COHTAC and SCORE website. KOHA forms are also available in a bunch of different languages. This will make the families feel included and supported. Next slide. This is the example of KOHA form. KOHA form has 3 sections. First is child demographic, assessment results, and follow-ups or waiver details. So accurate completion of all sections is critical for proper reporting and follow-ups. Next slide. To support this program, SCORE Access is very helpful to all LOHPs, and it lets you see what has been submitted by schools and spot gaps across your county, make data-informed improvements. So if anybody needs SCORE Access, you can send me an email. I'll be very happy to help you. Thank you so much. Next slide.
Thanks, Vaishali. It's great to get that overview and make sure we're all on the same page. Now for this next section, myself and Cherie Sprouse from Stanislaus will be covering Data 101 and some recap of the previous KOHA webinar, including some additional resources. Next slide. So first of all, I want you to think about how do we use data? what is data used for, and how can we use it to do different things that help us with our goals. So some of this, it's a lot here on this in this word cloud, but some of the different things are that it can help us with understanding population health around us, tracking things over time, seeing how well we're doing and doing evaluations, help us decide where to prioritize and spend money, as well as inform policy and decision making. And the different uses of data for these different outcomes can be a little bit different, but I'm going to start with a really broad overview of some things to consider when thinking about data. Next. All right. All right. So one point I want to bring up is that we are talking about surveillance data, which COHA can be considered surveillance data. This is just continuous and systematic collection, analysis, and interpretation of health-related information, something that's kind of monitored over time. That's what we'll be covering today. And the conclusions that you can make from data is only as good as the data that you're working from. And I know you guys work really hard to collect that COHA data, but as you know, there's lots of challenges and some limitations. So I want to just talk about how that works in data. Next. So the different components of data quality to consider are, and I'm just going to briefly go over them. You can always read more about them. But we have completeness, which is whether or not we have all of the information, like are the forms completely filled out. Uniqueness, that is the assurance that each record is distinct and not erroneously duplicated in a data set. So we have one record for each child, not two records. So this is something that TK and kindergarten concern shows up. Timeliness, so that's available when needed, it's up to date, and part of that COHA policy has a 12-month limit. That general visit needs to be, the COHA assessment needs to be within 12 months. So that's one of the ways that we ensure timeliness of our COHA data. Validity, this is the extent to which the data conforms to predefined rules and formats. And that's measuring what we expect it to. And then accuracy is the degree to which the data correctly reflects the real world entity or event that it represents. So this would be that the COHA form accurately reflects the child's oral health status. We're not missing decay when it's present, and we're not misclassifying healthy teeth as decayed teeth. And then finally, there's consistency, which is the absence of contradiction when comparing data across different data sets or systems. Next slide. So I've kind of distilled it down to these 4 things that I think are the most important to think about. Next slide. All right, so let's take a step back. If we think of COHA data, what are we trying to summarize? Next slide. All right, we're trying to summarize the oral health status of all kindergarten students in California, right? We're hoping that if we mandate screening for all of the kindergartners, that we can then provide a summary of all the kindergartners. Next slide. But how we get that data is pretty complicated. So we start by getting a form or an assessment per child. We get those from then we collect those at the school level or the class level. Then we might be entering it at the district level or maybe the county level. And all those districts within the county are putting in the data, and then we're able to summarize things at the state level. So there's a lot of different steps in there. And so the previous slide had a California that was fully Black that would show that that'd be the case if we had all the data from everybody. And this slide shows that, we might be missing, right? The teeny tiny dots that are missing would be missing a child, and the larger dots might be missing an entire school or an entire district that's not participating. And so our picture gets a little bit blurrier. So I have another slide to represent that. Let's go to the next one. So Vaishali went over this a little bit, but overall, this is the COHA process. We go from collection to data entry to data analysis, data interpretation, and data communication. Next slide. And this here is showing that we want all data from all children, all schools, and all districts, that in that blue left bar. But what we really end up having is, we lose some districts. In the next bar over, we lose some schools, we lose some children, and we end up with some data from some children, some schools, and some districts in that purple box. And if we compare that to our large blue box at the beginning that we're hoping to get, we can see that we are missing, right? So we have only a limited amount of information with which to make these inferences. And this is important both for data collection and data entry, right? Each of these layers you could be missing data due to not getting the forms or to not entering the forms all the way. Next slide. And so when we do data, there's always missing data, right? And so in epidemiology, what we hope is that data is missing at random, which would be this example here. We have a picture and just randomly missing pieces of our puzzle. And so if that's distributed randomly, we can still kind of guess what the overall picture is because we're missing just little pieces separately. And so this would be if different kinds of children, different kinds of schools, different kinds of districts are just sort of randomly missing, then we're like this, and we can get a decent picture of what the overall picture is. Next slide. What often happens is that data is not missing at random. We are missing data for maybe certain groups that it's harder for them to complete. Either the children, it's harder for them to complete the forms because they don't have access to a dentist or their families don't have time, or certain districts that are maybe under-resourced or less likely to report, just for example. And so when you start having the data missing, not at random, you're missing pieces of the picture, and you might not even notice that there's birds in the sky because those are not missing, because those are systematically missing. And so this is just an analogy to help you guys think about how having missing data affects how we can interpret what we have. Next slide. And then ideally, this is the goal, right? Okay, next. So now I've got Cherie to cover the recap of our last COHA webinar and some resources.
Good morning, all. So you all on this call are well aware how much time and effort COHA data takes. So really the school dental work group, program work group wanted to be really mindful about how we can develop something that really would be best supportive of this work. And so we knew we kind of needed to break it down within two different webinars. And so you can see here, the first COHA Part 1 webinar really focused on that data collection, the data entry, that was held in April of 2025 and touched a little bit on the data analysis piece, which we'll dive more into today, and really heavily focusing on that data interpretation, kind of how we can use data to inspire change and action, and then how can we communicate data in order to inspire that change and action. In addition to that webinar, that Part 1 webinar, I also wanted to highlight several other resources and tools. So next slide. On our the COHTAC website, they have several resources from already developed talking points to presentations, letter templates, the COHA starter manual. All of these resources are on the COHTAC website. Highly recommend taking a peek at those in addition to that first Part 1 webinar. Next slide. And this, I will say, this is my go-to spot for COHA. This really breaks down each of those steps that Vaishali and Kristen both kind of shared earlier. There are also videos that help, video tutorials along the way. For those, I'm going to highly recommend for those that are kind of wondering about TK and communicating that. I found it really helpful under the frequently asked questions, so don't overlook that lower half. And it also provides other templates and things that are useful. Next slide. So again, today we're going to be touching on these last three. So the data analysis, interpretation, and communication. And really how we can use our COHA data to really inspire change and action at the local level. Next slide. And Kristen and Vasheli both, I think, called this out a little bit, but really how we can use our local level. It's connecting kids to dental homes. We can use it to support and advocate for guiding our funding with our schools and really prioritizing our efforts and our limited time and resources that we have to help make improvements. Next slide. So again, I'm touching on the data really starts with one child, so that really micro level, but let's not overlook that. That's connecting kids with urgent dental care needs to a dental home. And then looking at it at the next level with looking at schools. So you may have all kids reporting and accounted for in one school, and you may not. You may have one or two schools in there, but that still is a part of that data journey. And then next into the district level and encapsulating that. And really that can help drive looking at the district level to gain support from those decision makers and superintendents. And then looking again at that county level, which really I wanted to highlight, this is our shared population headline indicator, and that we not only share as counties, but we also share with our state partner. Next slide. So that state level. So this is one of those population levels. So we have our big/little p level population indicator that we share, but then we also are able to come together and indicate along with the state level data. So with that, I'm going to hand it back to Janelle.
Thanks so much. That was a really great overview. Next, we'll take a look at COHA data at the state level, including key trends and what the data is telling us across California. So I'll hand it over to Shamila.
Thank you so much, Janelle. A very good morning to everyone. Thank you very much for being here today. My name is Shamila. I'm a member of the Office of Oral Health Surveillance and Evaluation team, and I work as an epidemiologist. So let's begin this overview of the COHA data as it is reported in SCORE. Office of Oral Health utilizes SCORE state report to analyze the COHA data annually for each fiscal/school year. So this slide is actually just a quick review of the COHA legislative timeline. My dear colleague Vaishali has already covered this part in detail and wonderfully. I'm sure that must be very helpful for everyone. So I think we can move on. So next slide, please. Thank you. So for the purpose of tracking COHA participation, Office of Oral Health utilizes the results-based accountability framework, which organizes performance measures into three categories. The how much, how well, and is anyone better off? So how much captures the extent of the program, the volume of the workload being done. So as you can see here, an example would be the number of students with proof of assessment and the number of school districts which are participating and reporting COHA assessments. As regards the how well, this focuses more on the access of the program. So we can see here that the good examples of that would be the percentage of school districts participating in COHA and the percentage of children with proof of assessments. And finally, anyone better off would be capturing the oral health outcomes, the results of all these activities. So of special importance here are these two measures which are highlighted. These are our core performance measures used for statewide tracking of COHA progress. And as if we see collectively all these measures combined, they give us a pretty comprehensive view of the overall picture of progress. So how much will be explaining to us the scale of the program, the how well would be giving us an idea of the extent effectiveness of the program implementation, and that anyone better off would give us an idea about obviously the impact of all those efforts on oral health of kindergarten children. So next slide, please. So this slide gives an overview of the most recent analysis of the KOHA state report from the fiscal year/school year 2024-2025. The slide focuses on the two core performance measures as I described in the previous slide. The numbers are here on the screen. So together, these two give us an integrated picture of both the children's participation in KOHA as well as the school district's participation. And combined, they give us a very good picture of our progress made in KOHA assessments and reporting statewide. Next slide, please. So this slide displays a trend over time for one of the two core performance measures, the percentage of California school districts participating in KOHA and reporting in score. This we can see that the trend has generally been an upward positive one. If you look at the numbers, the estimates from 2014-15, they have almost like more than doubled in the most recent years. So from 33% have risen to 68%. So this upward trajectory that reflects the continued progress and sustained progress in the participation by school districts and reporting. There has been some year-to-year variability, but it's very encouraging to see that the most recent years, they depict a wonderful desired upward trajectory and just reflects the continued progress statewide. And thanks to our LOHP partners for their hard work and dedication. I'll just take a moment to say that it's not possible without their hard work. Okay, so next slide, please. Thank you. So this slide displays the trend over time for the other core performance measure, which is the percentage of California children who participate in KOHA report those assessments in score. Again, there has been some year-to-year variability, but despite of those fluctuations, very encouraging to see again in the most recent years, there has been a pretty consistent upward trajectory. The most recent year we have seen that it's like kind of just touching our target our target value. Again, a reflection of our efforts, the continued progress, the sustained hard work and dedication, whoever is involved in this very important task. So yeah, so this reflects progress, a positive thing here. So next slide, please. Oh, I'm very sorry. If can you please go back one slide? Sorry for the inconvenience. I just wanted to quickly point out that there has been this dip seen around the time of COVID-19 pandemic. So those maybe the result of the disruptions caused by the pandemic, we can only assume, but there's definitely this dip corresponds to that time when the pandemic was at its peak. Thank you, Janelle. So next slide, please. Oh, sorry, Khadija is doing that. Thank you very much. So this next slide again provides a snapshot of the most recently reported data focusing on the two oral health indicators among kindergarten children. And together it provides us a good insight into the oral health of the kindergartners. It not only provides the burden of gives an idea of the burden of oral disease, but also provides the current level of needs. among the kindergarten children. And it's very important to monitor these oral health outcomes because they were very helpful in guiding our ongoing sustained efforts, both at the state level as well as the local level. Next slide, please. In the state of California, we have seen a substantial improvement in the oral health of kindergartners over the past 2 decades. So as we see here that the current estimates, the levels are already better than the targets which were established in the California Oral Health Plan. And we really hope that we continue to see the progress. And it's just reflects the ongoing prevention efforts, our ongoing efforts to expand access to care as well as early intervention, again, both at the state and local level. Next slide, please. So this is, again, a trend line chart that is displaying the percentage of California children with reported caries experience. Overall, it has been a very positive trend line in the sense that the estimates have steadily and consistently remained well below the target of 43%, which is obviously a very good thing. Again, a variability observed around the same time, which may be linked to the disruptions caused by the pandemic, but again, very heartening to see that the most recent years, the estimates have returned to lower levels, and they have consistently stayed substantially below the target values. Next slide, please. Yeah, thank you so much. So this slide reflects the percentage of California children with reported untreated decay. Again, this is for the time period shown. The trend line has remained quite steady, again below the target value. Some year-to-year variability definitely is observed here as well, but from the most recent years, there has been the estimates have rebounded, and there has been a clear recovery. And from the most recent year data, we have seen that the trend line is again showing a positive trend. The overall trend has remained relatively stable and throughout continuously below the target value of 22%. Which shows that there has been improvement in this very important oral health outcome. And on this positive note, and thanks very much to everyone, I'll just conclude my portion of the presentation. I'll be very happy to answer any questions during the Q&A session. I know that is something planned probably towards the end of the presentation. And for now, I'll hand it over to Victoria Oyeli. Thank you very much, everyone.
Good morning, everyone. Thank you so very much for joining the webinar. Thank you, Dr. Shumailer. Victoria Oyele, the Research Scientist Supervisor with the Office of Oral Health, Surveillance and Evaluation Unit. It's my pleasure to be able to present today, and hopefully we'll have more conversation in the chat after my presentation. Thank you. Next slide. So this morning, I'm going to be covering why KOHA data matters, impact of KOHA data reporting, and how KOHA data drives research and evidence. So what is the public health importance of KOHA data sharing and the quality reporting? So KOHA is known as California's foundational system for understanding oral health at school entry. It allows public health surveillance team to identify trends early and also track progress over time. So good data in equals good insight out. When schools submit complete assessment, into the score system, it produces higher quality analytic outputs. Accurate reporting enables identification of disparities and also supports targeted intervention. Looking at the KOHA data, this data is not just operational, it fuels real evidence-based publications and reporting. Currently, with the CDPH Local Epi Forum, the surveillance team at the state level conducted an assessment of historical data in KOHA, which fueled 2 abstracts for submission. One has been accepted for presentation at the CDPH Local Epi Forum, titled Careers Experience and Treatment at Kindergarten Entry in California, a population-based analysis. And the second is still awaiting approval from the APHA conference, which was submitted last month, titled Turning Data into Action, Population-Based Insights on Visible Untreated Dental Decay Disparities in California Kindergartners. So finally, I would love to say that data completeness is not just operational, it is very critical to our day-to-day surveillance and evaluation at the state level and overall. So when schools and providers and programs report complete and accurate assessment data, the state gains the ability to produce credible analysis, monitor trends, and also be able to design interventions that truly meet community needs. Thank you very much.
Thank you so much. Great. Now we're going to shift to the local level to hear how programs are using KOHA data in practice, including strategies, successes, and challenges. First, we'll hear from Shri and then Christy. Hand it over back to Shri.
Next slide. Next slide. So I'm going to share about how we go from reporting and to seeing some results and local change. Next slide. So our approach over the years, we really using that results-based accountability framework. They have a tool, it's called Turn the Curve Thinking. It's a 5-question tool that you continually ask yourself. So looking, once you pull the annual data, how are we doing? What's the story behind the curve? I want to highlight this. This has really been an important element that we're mindful of, especially when we have some new changes that it takes a while to roll out, like the TK being added to the kindergarten program, when the surveillance of the urgent dental care needs and the confusion around who's responsible for filling that out. And that data still is looking a little murky. But if we're just documenting the story behind the curve and why we're seeing potentially some changes in the trends over time, really is important. And it also is because in question 3, we identify who has a role to play in that. And it helps us then bring in the right partners to help us improve our data. And then question 4, it's what works? Like, this is where you're coming up with these innovative, crazy approaches, but then being realistic and feasible, and then honing in and deciding, so what do we propose to do to hopefully improve our data or drive some change into changing and turning the curve to where we want to see things looking. So that's been our approach over the years. Next slide. Next, oh, there we go. And so really, I'm going to go back to 2018-19. We really just were focused on basic learning and the KOHA data and reporting into SCORE and familiarizing ourselves. And then 2022, 2023, coming out of that lovingly referred to as COVID coma, we're not only looking at our KOHA data and into SCORE, but also we did a local level policy scan. And then really our next approach and biggest change was in 2025-26. And we decided we were going to take some local level action and develop some report cards for our local level decision makers. So I'm going to dive into these things in a little more detail now. Next slide. Oh, the beginning. Oh, the learning, right? When we all first start diving into our KOHA data and really looking at that district level and school level and reporting into SCORE, but then also the number of COHAs actually being accounted for into the system, and then how many waivers and what the data that we were able to collect and looking at oral health outcomes, so that treated and untreated decay. So really our goals back then were just to establish some baseline data and establish some targets and some goals for ourselves, and then developing those relationships, those partnerships that we really needed to develop in order to see some change. Next slide. And then in 22-23, we continued to look at that data again, but really that's when we started documenting the story behind the curve. So those little nuances and things, and this is also where we realized, because we have learned over time that each of our school districts' approach to how they capture the data and enter the data and whose responsibility it was varied across all 25 of our districts. So we really needed to then do a policy scan to help inform and still continue to learn. And then we also, now that we had some baseline data, we were looking at tracking progress over time at our district level, and then continually engaging partners was our goal there. And the newest addition, which is why it has a little red asterisk, was this is around the time that we were not only recovering from COVID and realizing that, you know, dentistry was the only healthcare system that shut down completely during COVID. So we had to do some recovery with that. But then we also had that new addition with the new COHA forms of that urgent dental care needs and follow-up and who's responsible for that. And they weren't sure how to enter it, and working through all of those challenges. So really documenting, again, that story behind the curve. Next slide. So then that really, in doing that policy scan, we were able to then develop some gold standard recommendations in working with our partners. So that looks like one school district, for instance, school nurse was really passionate about not accepting waivers and working with the families to get their child into a dental home and really getting them screened and ready to be the best scholar that they can be. Also, on-site screenings with passive consent was another gold standard that we found from some of our school districts, and then also working through those challenges collectively. So with that, we were able to not only develop some gold standard recommendations, but some training, we put on some trainings for our local partners, school nurses, and decision makers to then tackle some of the new challenges like those urgent dental care needs and referrals. So next slide. And so some results from those actions, we were able to see from our 22-23 data to our 23-24 data that more kids were screened. So 10% increase in that. We've seen some maintenance, which is also a success, is that we didn't see any more waivers. So we didn't decrease, but we also didn't increase. And then our number of no responses decreased by 3%. Next slide. So then in 2025, 2026, we still were continuing to look at all the levels of data, continuing to then document our story behind the curve. So why are we seeing the trends that we're seeing? And then really using that data to drive what kind of actions we need to take to implement and see hopefully some changes. This is the addition of TK COHA, who was our biggest documenting the story, the story behind the curve. Like, why are we seeing our data get a little wonky here? And then also continuing to track our progress over time. And again, continuing to engage those partners. So what we developed, next slide. To do that, we were thinking this time we needed to engage rather than just our school nurses, but really our decision makers, our superintendents. So looking at that district level. So we developed a cover letter and we sent it out to each one of our school districts along with, this is a sample report card that then also showed our data. In the middle there, it looks like little calendars, and you can see there's only one checkbox in 23-24. Well, they hadn't been reporting up until then, so it also shows them over time. And then breaking it down about waivers, no responses. And then if they had more than one district one school in their district, we also were able to break down some of the data. So we kind of told on some schools that weren't doing so well to their big boss. And we have seen some more engagement from school districts and from schools themselves. This also went out to the school nurses, so we didn't do it necessarily behind their backs. We still were engaging those partnerships and didn't want to burn any bridges. But we thought sometimes they need some support from their decision makers. So that kind of was our approach for 25-26 this year. And we're hoping, next slide, to see our fruits of our labor when we pull the data for progress reporting this year. So if you have any questions or want to reach out to me, if you would like those templates for that report card, please feel free. Here's my contact information. But with that, I'm going to kick it off to Christy in San Diego County, and she's going to share some more local level learning and successes.
Thank you, Cherie. The report card is really, really beautiful, just have to say. So I'll be sharing strategies, examples, and challenges using COHA data from San Diego County's local oral health program. Next slide, please. A school's COHA data can identify unmet needs and potential challenges and help to engage schools and tailor solutions. So I'll give some examples of what you may see in your COHA data, challenges it may indicate, and actions to help address them. This can be helpful when thinking about what support the LOHP can offer with the resources it has. COHA data is one piece of the puzzle, and connecting with school staff can provide insight on specific challenges in their community. So if you notice low school reporting, it can indicate a lack of resources and capacity needed, the school not being aware of the reporting requirement or process, or challenges using SCORE. Reaching out with information about the reporting requirement and offering technical assistance or training could help with some of these challenges. It could also be that the school may not be getting any assessments or forms back. So instead of reporting 0, they may not report at all. Next slide, please. If you notice a low number of submitted assessments, it could indicate parents not being aware of the requirement, challenges with access, loss of the form anywhere from the parent to the dentist and back to the school, or convenience of just completing the waiver. Or if a school partners with a provider to do screenings, they might not be using the COHA form. Some potential solutions are asking the school to promote Smile California and send reminders throughout the year, engaging local providers to have the form available in their office or complete the form during on-site school screenings, educating parents about the assessment, and having the program coordinate on-site screenings if the school isn't already working with a dental provider. Next slide, please. And for students that were assessed to need urgent dental care, if you notice low or no follow-up at all, it can indicate confusion about whose role it is to follow up and complete that section, or the school may not have a process or capacity to follow up. It could also be that follow-up is being conducted, but it doesn't get documented on the COHA form, and so it's not reported. A potential solution if the school doesn't have capacity or follow-up process is encouraging the use of the Medi-Cal Dental Care Coordination Referral Form if the student with urgent needs is on Medi-Cal. They may not get the information back about the outcomes to document on the COHA form, but at least the family will be followed up with and hopefully linked to care. So these were just some examples of solutions, and if there are others that your program or schools have used to address low school reporting, assessments, or follow-up, please feel free to add them in the chat. Next slide, please. There are additional factors that can be reflected in the data as well and challenging to address, such as reduced access to providers due to changes in Medi-Cal, how the school is reporting COHA results for TK, impacts on school funding and resources available, and if the school has partnerships with providers that would need to be engaged around using the COHA forms, using passive consent, conducting follow-up, and reporting results. Next slide, please. These are some data-driven strategies used by LOHPs that were shared in the data subcommittee, and this is by no means an exhaustive list. So if there are others your program or schools have used, please add them in the chat. And some of these are more resource intensive than others. So based on what your program and schools are seeing from the data, what COHA outcome you want to improve, and the existing partnerships that you can leverage, some may be more feasible with the resources available than others. Next slide, please. So I'll share a few examples of how San Diego County's LOHP has used COHA data. Next slide. We've used the COHA data to inform school outreach and engagement each year by merging it with free and reduced price meal eligibility and data on community conditions from the Healthy Places Index. This has allowed the program to focus on specific districts and schools, narrowing a potential pool of over 400 schools to 119 when we first used this method, which can be really helpful for strategizing use of limited resources. Next slide, please. One example of success we see in the data is for a rural school district in Fallbrook. The Fallbrook Smiles Project had previously provided dental screenings to schools in this district, but the pandemic had impacted their funding and operations. As a result, the district had a low percent of COHA assessments reported. So the county LOHP, the district nurse, and the Fallbrook Smiles Project collaborated together to bring volunteer dentists from the area and the local dental society to conduct on-site screenings with passive consent, as well as nursing students from the local university to provide oral health education. And from their COHA data over the last 3 years, we can see the need for support to increase assessments, and we can see the effectiveness of using passive consent. Next slide, please. Another example of a success is with the La Mesa Spring Valley School District. The program in this district have developed a strong partnership over the last few years, and the district nurse has been very supportive of oral health efforts and is a member of the program's advisory board. The program's effort started with a pilot to increase assessments at a small number of schools and expanded to executing a memorandum of agreement, or MOA, working with more schools and using COHA data to inform their on-site screenings. This district does have a partnership with a community clinic to conduct the screenings, and in school year 24-25, they made the switch to using passive consent. Their COHA data from the last 2 years shows the positive impact of making that switch on increasing assessments. And my apologies on the visual. There should be some little light green dots from 2023 to 2024 that for the most part are on the left-hand side, and then the dark green dots are mostly on the right-hand side. There were a few schools where it was a little bit switched, I think probably just for Murray Manor, which is in the middle. But for the most part, we did see an increase in assessments from 23-24 to 24-25 school years. Next slide, please. I'll share some challenges and limitations that we've encountered with turning COHA data into action. Next slide. Communication with schools can be challenging. While the data can identify schools that may need support, those schools may not have the capacity to engage with the program at a given time. And over the years, we've also worked with schools to increase assessments and follow-up, but sometimes the results of those efforts don't get documented in the COHA reporting, and so they're not reflected in the data. And this can be challenging when trying to assess effectiveness. And that's why it can be helpful to lean into tools like RBA and using success story narrative to fill in those gaps. Maintaining a level of effort is also an ongoing challenge. It can take a lot of program staff time to do outreach and engage schools, build relationships, execute agreements if needed, coordinate on-site screenings along with other school dental programming like education and preventive services. So given limited resources, it can be challenging but may be necessary, especially in these times, to have sustainability discussions with partners to identify where the program can maintain the same level of effort, or if there are roles that school and community partners can fill. Next slide, please. In our county, we also only have access to aggregate school level data, so that limits the analyses. For example, not being able to look at oral health disparities by race or gender using COHA data. I may also have to omit a school's data from analyses if it doesn't meet certain data quality criteria, and that was touched on earlier in the earlier in the share and learn. This can be a result of forms that are not completed as intended. School non-reporting and student non-response also contribute to not having a representative sample. And so while it can be challenging communicating COHA data and results with these limitations in mind, the COHA data can still be a very helpful tool for engaging stakeholders in a meaningful and impactful way to encourage and drive action. Next slide, please. So I'll end, and I just want to acknowledge and thank the members of the data subcommittee for their input on developing these slides that I presented. And a quick shout out to my San Diego colleagues on the call who work closely with the schools on the ground to support them with screenings, education, preventive services, and more. So I appreciate your time and attention and the opportunity to share. So I'll turn it back over to Janelle.
Thank you both. That was really, really cool to see how you're implementing it in your counties. It's really encouraging. So as we've heard, collecting data is just the first step. Now we have to think, how are we going to use it? So this next section introduces results-based accountability, a framework to help turn data into action. Over to Kristen.
Great. Thank you. Next slide. And so you guys have heard RBA a couple of times. I want to just reorient us to this whole process where we go from data collection, entry, and analysis, and interpretation and communication. So on the right-hand side, this data interpretation and data communication is really what this webinar is focusing on today. We've just had some great examples from the LOHPs, and RBA is a great tool that can help us with that data interpretation and communication part. So I'm going to very, very briefly just provide an introduction to that and some of the resources that are there in case it's new to you. Next slide. All right, so it's a RBA, or results-based accountability, is a framework for quality improvement. It's simple and practical. It's the company that does it is Clear Impact, and it's used widely by health departments, including the California Department of Public Health. So a lot of your general health departments might be using it for other things. It's not oral health specific. And it's something that we've been encouraging to use with your oral health parts as well. So it helps us shift COHA from not just collecting compliance data, but to actively improving children's oral health outcomes. So we're linking that data quality and program performance to real world impact and informing the players on the ground about this to continually improve it over time. The QR code here will go to the RBA webpage on the COHTAC website, and we'll also put it in the chat. And on there is a overview webinar as well as some other resources in case RBA is new to you. Next slide. So this is already briefly covered by the LOHPs, but we're basically asking, how much did we do? How did we do it? And is anyone better off? Next. So how much did we do? Let's go ahead and go through click it 2 more times. Khadija? Yeah, thanks. All right, so how much did we do? This is the percent of kindergartners with completed oral health assessments, and also the number, and the number of schools submitting COHA data. How well did we do? The percent of forms that are complete and error-free are submitted on time, and then is anyone better off? Number of children, the percent of children identified with untreated decay receive follow-up care, and reduction in untreated decay rates over time. Next. And from taking that, we can do the turn the curve sessions, which people also touched on before. We're looking at the data and ask, how can we improve? What do we prioritize to improve? So for example, if your completion rates are low, you've already heard some great examples from the LOHP. So you can partner with schools, simplify the forms, increase parent reminders, hold in-school screenings with passive consent, right? These are ways to focus on that completion rate. If the data quality is poor, if the form is having errors, you might want to work on training providers or adding validation checks along the way. And then if we have issues with follow-up, you want to strengthen your referral systems and care coordination. It can be really overwhelming to do all of these at once. And so breaking it down into pieces helps us identify and prioritize. Let's focus on one part first, and then we can slowly add it as we gain success in that area. Next slide. And so on the COHTAC webpage about RBA, which we developed with Office of Oral Health over the last couple of years, is some different tools and examples that can help you in that data communication process and that turn the curve process. So we have process maps, which these little icons, these little pictures on the right are examples of process maps. and infographics that help you communicate your COHA outcomes and your data to different stakeholders. You can tailor these to like a parent audience or a school board audience or your advisory board, maybe that has providers on it. And these are really helpful at advisory board meetings or other areas where you're trying to partner with other people in the community who can help you reach your COHA goals. Next slide. All right, that's it for now. But if you haven't been that close with RBA data, I do recommend you check out the website and to get some of those examples. We have now Marina from San Francisco and Jodeci from Fresno who are going to talk about some of the ways that they are communicating their COHA data.
Perfect. Hi, good morning, everybody. I'm going to steal your screen. Oh, I'm going to steal your screen share, but you're welcome to include that in the slides or follow up. I'm going to share our dashboard. Yes, I shared the right slide. And I'm going to put it also in the chat if you want to explore it on your own. So our dashboard, give me 1 second as I orient with all of my multiple screens, really went live in February when we had the really like a public release of our strategic plan or the health improvement plan. So we wanted to make sure that anybody who engages with our health improvement plan also has access to these data. So the current and this dashboard, I'm going to scroll through it real quick, and then I'll go into some of these. Like there's a status scorecard with some of our strategic plan goals. There's time trends where we track, or rather show their rates of carries over time from when we, as far back as we have digital data available. There's some disparity data as well, and maps. And if you're playing around with our dashboard, you can take a look there. It's not just our COHA screenings, so that would be the DPH dental screenings. I know it's super tiny. I'll zoom in a minute. But there's also our Head Start data, our ER data, our hospital admissions data, the MIHA data. You know, there's a bunch of other various data sources that are all in that same dashboard. So we, as I was showing you, if you go on our dashboard and you click this little button, it'll open our data graphs in a separate window, and it's a lot easier to see. That's why it's like, give me a second, I'll zoom in. So all of these dashboards, all of this, like, this is the graph I wanted to show you. This is all of our, like, the COHA screening data. And as you see, we go back quite a long way back because we started doing the school-based programming and school-based screenings back in the early 2000s. And so the data was tracked and collected in Excel spreadsheets by our maternal and child health epidemiologist, who was just always really passionate about oral health, but also data. As any epidemiologist is, she is a true data nerd and was collecting and tracking these data. So that epidemiologist has been involved with our efforts, oral health efforts, since the very beginning. So I know one of the questions came out, it was like, oh, how did you advocate for this, for the resources for these data? And really it's Jody. It's Dr. Jody who was really insistent on making these data available. And that, like, being able to build these Power BI dashboards really came out of COVID. You know, one of the few positive things that came out of COVID is that there was a demand, I'm sure on your health departments as well, to provide that live COVID data, the infection rates, the vaccination rates. And so that our IT department was able to build the kind of the website backend capability to pull the Microsoft Power BI onto the SF.gov website. So because that back end was already built and we had that epidemiologist who knew how to put it together and was really passionate about having it public and displayed, she really took the reins and built these dashboards. So you can, I can reset it, but this is, for example, our KOHA data. Here you have the white kids completing the KOHA, and then the kids of color are coming in at a much higher untreated decay rate. If you reset it, you can look at other variables. So that was the untreated dental decay. So the DPH screenings. You can do the urgent dental problem. And you have to make sure you click all of these buttons. And if you're playing around with it, to select multiple, you have to use the control key. Otherwise, it will just switch from one to another. So this is the urgent dental problem identified. And unsurprisingly, after COVID, we're going right back up where we started. Before we started doing some improvement work. What I also really like is the map feature. So this, the colors are not ideal. I think the colors we have a little less control over. But this is kind of my favorite feature because you can see really where the geographic gaps are. So this is before we got really going on interventions, 2007, 2012. And it's combined because of the low number of kids, and we don't want to make sure that the kids are not identifiable. So right now you're looking at the dental screenings, just rate of caries, kindergartners in that time period. And you'll see our southeast portion of San Francisco are coming in at almost 50%, and then Chinatown coming in at basically 50% of the children had been identified with caries. And this representation is what really kicked off our local efforts and the need for strategic plans, saying, showing to our local board of supervisors, saying hello, every other kindergartner in some of these neighborhoods, has caries. We got to do something. And so if you look then at 24-25, so that's last school year, you'll see that the scale doesn't even go up that high. We have a couple of neighborhoods that are now in 1 in 10 kids with caries. Even the Chinatown, Southeast, right? We went from 1 in 2 in the Southeast to, 2 out of 5. So it's slowly going down, the kids in the Mission have better outcomes. Chinatown has better outcomes. The western side of the city has better outcomes. So I really like looking at the map that what we're doing is working. And as I said, because the dashboard is brand new as of February, we haven't really used it very much. The data we've been using, but the actual dashboard we haven't been using very much. So we our entire health improvement plan and our as I mentioned, strategies of our LOHP are really dependent on the data. So being able to show it in a dashboard is really useful, because then we can have it in a meeting and say, okay, don't forget to go look at our data, right? If you're interested, go look at our data, and just having it publicly available, not in a PDF format, but kind of in a more interactive format. I anticipate being really helpful for us and for our partners to be able to have these data in a more interactive way. And that's it for me. If you wanted to see all of our other things, like the NEHA survey data, the Head Start, the ER visits, the ER visits is what we're going to be looking at a little bit more as medical health keeps getting cut and cut. So we anticipate this to be useful and to kind of add to that transparency. Oh, and I had 1 minute left 6 minutes ago, so I'm going to stop talking.
Thank you so much, Marina. That's really neat to see the dashboards. We're going to pass it back to Jodeci.
Thank you. So I will be quick. We developed this from the RBA training. So the goal when developing this infographic was not to only use it as a visual, but also as a tool to support, partnership, spark the conversation, make it really easy to understand, and also to inform key decision makers. So just briefly, the infographic highlights key data from SCORE. So we did utilize SCORE specifically for Fresno County, just to give a quick snapshot of where we are at. So it doesn't show it on here, but for 24-25, we screened 1,038 children for completing a KOHA. And then right now we are on target at 1,029. So it's been staying consistent. And, we hope to increase. Fresno County does have 32 public school districts with more than 200 schools. So we are trying our very best to inform, all of these school districts and nurses and key decision makers. So we really wanted to grasp the intention of this when being at school meetings or connecting with partners that can provide potential sustainable funding. So in addition to the KOHA data, we also highlighted and referenced our 2023 Fresno County Community Health Assessment, which really just highlights the top 5 needs. And that includes also maternal and child health, as well as access to care, which is one of our key target populations and priorities for our local oral health program. So this infographic has been shared with our school partners in efforts to really communicate the impact and inform of, what is a KOHA, why it's important, and then how we're looking like in regards to reporting. And we've included this information also in past presentations to partners, just to be able to demonstrate to the partners our school-age children needs, and then also to support early prevention. So we really discuss, why is KOHA important, and then from sparking this discussion, what can we do for next steps to support our schools. So there is a more opportunity to be intentional with, how our LOHP utilizes this infographic. So taking this into account and kind of hearing from everyone else as well. I feel like one thing that we can do is also pairing it with next steps, whether it's, expanding school-based services, what can we do to kind of support them? So really just sparking up the conversation and continuing to provide that support to the schools, and then also aligning our resources or identifying any gaps. So really this infographic is more to just give them a quick snapshot, but then also follow up and continue to engage that conversation and provide a little bit more data on, the urgent needs, cares, experiences within the schools. And this would be directed specifically for individual school districts as well. And also using it to continue to start that conversation with partners and ask them, how it connects with their work and what stands out. So in all, this infographic was made to make it easier to understand and also to help strengthen our partnerships. So I really want to thank everyone for, all of the feedback and everything. I feel like we're definitely going to take that back. And I really love the dashboard. That's really interesting, and all of the information that is provided in today's Share and Learn. And I'll pass it back to Janelle.
Thank you. Yeah, it was so cool to see the visuals. I think it's so hard to design, but all of them looked really, really great. So thank you all for sharing. Now we'll move on to our question and answer portion. Please continue to drop questions in the chat. I know that a lot of the questions have been answered, but we'll still address a couple more. One question we did have in the registration was around data cleaning, so I thought I would start there. Christy, did you have any, would you be able to share how you approach this important aspect of data collection?
Sure. And some of this came up a bit in the chat, but I recall like in earlier years, SCORE wouldn't accept aggregate school level data that didn't meet the criteria of the total eligible number of students equaling the sum of the number of reported assessments and the number of reported waiver options, plus the non-response. So if the eligibility reported number didn't equal that, it wouldn't even accept it. And we were using the bulk upload option. And so it took me a couple tries to be like, why is my bulk upload, why is my data not being accepted? So I've had to screen out the school data that doesn't meet that criteria before uploading it into SCORE beforehand. But also when doing the local analyses, I'll omit those schools and separately track the total number of schools that did report any data, just to get a sense of, okay, these schools are aware of the reporting requirement and how to report, and then separately track the number of schools that meet that data criteria and are able to be used in the local analyses. Some variables that I don't include when putting together a results summary for our county are Carrie's experience and follow-up, just because I'm not, when looking at the data at the aggregate level, I'm not able to always make sense of it. I think for us, the Carrie's experience is likely an underestimate because it doesn't always get checked along with untreated decay. And so sometimes we'll see the aggregate untreated decay number higher than the Carrie's experience number, which shouldn't happen if it is being recorded as intended. And so that can be really tricky with interpretation. So I will often not include that in my results summary. And with follow-up, it's kind of similar. I'll see numbers for the follow-up being larger than the number of reported urgent cases. And so I won't, it's important to note okay, I'll need to maybe follow up with that school and district and kind of ask what their follow-up process is like, if they're following up with all students about the result, regardless of whether that child has an urgent need for dental care. But in terms of reporting it as intended, like of those kids that had urgent care, I don't report like the number that received follow-up because I'm not able to discern it from the aggregate data. So those are the two main, or I guess some of the main data cleaning that I do, along with, making sure the CDS code is right, the names match what's in CDE.
Yeah, there's a lot of different aspects to entering everything into SCORE. And Cherie, did you also?
Yeah, I just wanted to jump in and again put a plug in for our if I can share my screen for the webinar. Can you all see for the first webinar that the link was in there? I highly recommend for those that are struggling with that initial data. And then also going to the COHA online kind of toolkit and going to the data form. It also highlights where this tool, thanks to San Mateo County and Claire, you can copy and paste your data into, and it'll produce really pivot tables and infographics and things like that for you. So I highly recommend reviewing that. So there's those tools that are helpful, but there, unfortunately, what Christy was talking about, there still is that level of having to clean up. But if you're having high schools or continuation schools or schools that will never have TK, COHA, or kindergarten first graders, reach out to SCORE, and then I'm an advocate too. If SCORE is not being responsive to you, reach out to the Office of Oral Health and COHTAC so they can help champion that request, because that is the role that they play to help support us in being successful and our data. If Shelly is giving a thumbs up, reach out to her. She will gladly help support you. So help clean up that data long term, and doing that is really beneficial. Unfortunately, if you have schools that were open and have now closed, they need to keep those schools. So those will continually show up on your COHA. But again, documenting that information about the behind the data, the information. So those are kind of I wanted to plug in those tools. They're fantastic, but unfortunately, you're still going to have to do a little data cleanup in there and being mindful of what is that data telling us? There's a whoopsie in there somewhere. So what do we need to do?
Yeah, I was wondering, how is your relationship with all of the schools or even the districts or the schools? Like, do you coordinate specific times to meet for data collect or for COA when you're putting it in or they're putting it in? Or do you have any standardized like regularly scheduled times that you meet with everybody, or how does that work for you guys?
I personally don't. It's based on they reach out when they need technical assistance and support because it varies and because there's staff turnover. That's at least for in our county in Stanislaus.
In San Diego, we have a partnership with the County Office of Ed, and they've helped us convene the district nurses for like quarterly meetings, or I think we meet 3 times a year, and then we also provide office hours in the couple of months leading up to score reporting, or the COA data reporting.
So your focus is starting, well, I guess a few months before May until May 31st. Is that when you really try and get everybody to put it in, or do you start in the beginning of the school year?
So the earlier meetings throughout the year, they focus on more than just COA. It's also inclusive of promoting oral health like at the school level, and if folks are interested in education or preventive services in addition to on-site screenings. And then with COA reporting, we started an earlier focus because some schools end before May 31st and are needing to report before that timeline. So we actually had our first, I think, office hour or training around data reporting in February, and then office hours in March. We just finished 2 in April, and then we have 2 more in May. So we try to offer a lot of opportunities to reach out and ask questions and get assistance.
Oh, that's great.
Sorry, I know I wanted to also put in a plug for Sacramento County Sacramento County's oral health program, excuse me. They're having a COA workshop training series, and the first session is in 2 weeks on April 28th. So keep an eye out for the registration information. So just want to share additional resources coming. If you want more information about COA, that 3-part training series is coming soon.
Thank you so much. So we have time for a couple of questions. I wanted to acknowledge Rebecca. I saw your question early on about new or better guidance regarding addition to TK to reporting. Is anyone from the Office of Oral Health want to add to this question or answer the question?
Dr. Pendekar answered it in the chat.
Oh, she did. Great.
I mean, a little bit. They're
working on it. Is that right? They're working on getting guidance. I'll try and ask.
Yeah, and especially because of the COA audit, it may be slower than we want because there's a lot of factors at play. Yeah.
Great.
But they know soon would be great.
Xenia, did you see any questions that weren't answered in the chat? Everyone did a really great job with contributing to the conversation, so thank you so much.
No, I don't see any unanswered ones, and then we'll post the Q&A from the chat on our website afterwards as well.
Great. All right, so we're gonna launch the evaluation poll now. We ask you if you wouldn't mind taking a moment to respond. We really value your feedback and especially the written responses. We spent a lot of time looking at your answers.
As you guys are filling that out, I just want to impromptu say a few words at the very end that I know we sometimes get tripped up on like data quality and all, there's so many things that can go wrong, but at the end of the day, every single form that comes in is a child who we now know about their oral health status, and it's an opportunity to make sure that that child or that classroom or that school or that district, right, is getting those children connected to care. And so, why it's great to have, visions of perfection that we'll be able to overcome these challenges. And you got to see from Shamila's presentation that we are slowly making that progress. that whatever stage you're at, whatever stage each particular school is at, is, it's where we are, and there's benefits to that. And what the benefit is at the local level, right? Some of the things might be difficult to translate to the state summary, but at the local level, those are kids in our community that we can help, and we can use that data to engage our community. So thank you guys for all the work you do on COHA. I know it's a lot.
Also, thanks, Kristen. There is one unanswered question. Any updates on provider training for KOHA?
Yes, we have. I want to thank everybody who gave input on that. We've heard from LOHPs that they really want provider training for KOHA, so we've had a couple of meetings and worked to develop that, and we have a draft that we're sending to Office of Oral Health for their review. And then we've figured out ways to partner with different organizations like the CDA and the Pediatric Society, California Pediatric Dentistry Society, to share that once it's ready. So you guys will be hearing more about that, but it has to go through approval process still.
We also have one more question too. If the schools do not report, what are the consequences for that? We had a few schools ask. What do you guys tell your schools?
I'm happy to jump in with my answer. I don't know what the formal answer is. I don't know what the legislation answer is. I don't think there is anything written in the legislation about not reporting, but in practice, the answer is none. There are no consequences. Our school district is insistent that all they are required to do is collect. So they collect COHA forms, but they are not interested in reporting, don't have the capacity to do the reporting. We haven't reported COHA at all until last year. And even those were based on the DPH screening that our team had completed, because the way, I think there was some earlier questions about the systems that the schools use to track the data, and our school, like one of the barriers besides staffing for our school district is that the way that their student records are set up, it's a yes or no checkbox. They turn it in, they didn't turn it in. They don't collect any, like they don't enter additional data. They just upload the COHA form to the student's profile. And it's either, is it uploaded or is it not uploaded? So we're not able to like extract any data for the 4,000 some kindergartners that are enrolled in our school district. So like I said, practically, there's nothing, there's no incentive and there's no punishment.
Thank you.
So I'll just add real quick, formally there is no, consequence. However, I do think that by having those conversations and those turn the curve sessions with those districts, you can start showing them and telling them about other districts who are reporting, and show, look, this district started doing it, and look what we've been able to do over the last, couple of years. Look how we've been able to track this, so you know more about your students, and oral health. Better oral health is better school attendance, right? And so there's nobody monitoring it on the, the formal way that there's going to be any kind of punishment, but using some of those positive factors to encourage them and show examples of success might be a way that you can, use the carrot approach to encourage them.
Great. That's all great. Yeah, we have a few more quick announcements. There's some upcoming events you might be interested in over the next few months. We also have several additions to the COHTAC website, and these are all posted on the homepage carousel. The Office of Oral Health SharePoint training materials are all available. If you weren't able to attend a training, you can use the link provided to request access to the SharePoint site. We also have a page from the Office of Oral Health with LOHP RFA resources that you can also find under the CDPH Office of Oral Health drop-down menu. And lastly, we have new fluoride resources, also found in the water fluoridation page. But thank you so much. We're going to close that poll. Thank you so much for your time today, and we'll see you next time. Have a great day. Thank you.